Dr. Zhenxun Wang from Singapore to share with us, very interesting work that he's conducting in the series Singapore. Thank you, Dr. Wang.
So can anyone hear me? Okay, so I thank the organizers for inviting me here. I'm a basic scientist. I work on exfoliation syndrome. And essentially, exfoliation syndrome is defined by the presence of this white specks in the eye. We are trying to find out how this arises and how do we control them. I have no conflict of interest. When we talk about exfoliation syndrome, LOXL1 is the most important gene. We know that common variants are associated with protection, but sometimes the effect is flipped. And rare variants, my collaborators did a survey a long time ago and found that they are enriched in controls, which means that they're associated with protection. But somehow it's also paradoxical because LOXL1 protein itself is a constituent of exfoliative deposits. And LOXL1 expression in the anterior chamber is increased in early disease, but decreases in advanced disease. And the second gene I'm talking about is really CYP29A1, which is a metabolic gene that we discovered to be associated with exfoliation syndrome a few years ago. Essentially, if you are an individual who carries a loss of function allele for CYP29A1, you have about twofold increased chance of getting the disease. Importantly, people with this particular mutation in the Japanese also have an increased risk of progression to blindness. The most important thing to take note for this talk is that CYP29A1 expression is downregulated in patients, even if they don't carry CYP29A1 mutations. So that's a key point. And the next question we ask, since we have both the presence of protective LOXL1 mutations and deleterious CYP29A1 mutations, is do we have people who carry both? And if they do carry both, what is their phenotype? So we looked at our patients, our cohorts, and essentially we found 4 such individuals who carry both protective LOXL1 mutations and loss of function CYP29A1 alleles, and all of them do not have the disease. So it appears that LOXL1 mutation overrides the risk imparted by CYP29A1 mutations, and that was our impetus for starting this study to look at both CYP and LOX in the same cell. So to do this, so essentially these are the alleles. We use RPE cells simply because we can't find any ciliary pigmented epithelial cells, but we know that they're continuous in the anterior chamber, and they also express high CYP expression in both the RPE and the ciliary epithelium. So the important thing we know is also that they express LOXL1 endogenously. As you can see here in the cell lysates, you see that there is you can detect LOXL1 in the cell lysates. Most importantly for this talk is that you can take the spent media and you can do a fractionation. You can detect the soluble LOXL1 in the media, and then if you do a very high G ultracentrifugation, you can also find insoluble LOXL1 in the media as well. So if you look at, and then if you express LOXL1 as you would in early disease where LOXL1 expression goes up, you see that there's an increase in LOXL1 abundance in all fractions. So if you do IF, you will find that LOXL1 does not colocalize with intracellular markers. It actually colocalizes very strongly with fibronectin, which is the ECM, the extracellular matrix. So how do we model loss of CYP29A1 expression? So essentially, this is the pathway here. If you have loss of CYP29A1 function, you're going to have an increase in 24-hydroxycholesterol because that's a substrate. And we also know that 24-hydroxycholesterol is a ligand, or because it's oxysterol, of LXR, which is a very, very well-characterized nuclear receptor. And of course, we do have inhibitors that inhibit LXR. So what we did was simply take LOXL1 overexpressing cells of RP cells. We treat them for 48 hours. we don't see much happening in the lysates, but you see 24-HC treatment causes LOXL1 to dissociate from the fibronectin fibrils, and they appear to be more diffuse. If we look at the culture media, which is essentially extracellular space, see that there's a strong increase in both soluble and insoluble LOXL1 in the cell culture media. And this is caused by LXR activation, because if you then co-treat with GSK2033, you can reverse the effects. So an important thing that LXR does, very well known, it causes cholesterol to move out of the cells in a process called cholesterol efflux. So we ask the next question, which is, can the loss of cholesterol itself be sufficient to cause LOXL1 to be released from the ECM into the cell culture media? And to do this, we simply strip cells with MBCD, as you can see here. Once you have MBCD treatment of cells, you simply replicate what you see with 24-HC. Loss of cholesterol, again, leads to an increase in the LOXL1 soluble fractions in both in cell culture media, and you can also see that this localization pattern resembles 24-HC. So here, we essentially show that increase in 24-hydroxy cholesterol leads to LXR activation, and LXR activation causes cholesterol to leave the cells, and this essentially causes LOXL1 to be removed and goes into the cell culture media. Now, this is all well and good. This is in cells. Can we see in the patients? That's the most important part. So essentially, we looked at markers of LXR activation in aqueous humor simply because they are most correct approximation for extracellular space, because they are essentially extracellular fluid. And then we're very lucky to get a lot of aqueous samples from Dr. Ozaki, who's sitting there. Essentially, we can use mass spec to quantify the amount of esterified cholesterol species in the aqueous humor of patients. And as you can see here, there's a very strong and significant increase, especially in patients who have late-stage exfoliation glaucoma, when glaucoma is already observed in their eyes. And so this tells us that at least in this cohort of patients, LXR is activated. And it's most likely because of loss of CYP29A1 activity, either due to mutation or decrease in expression. So can we model this in our cells? So we can, because we can now express CYP46, the upstream enzyme, and we can see that essentially 24-OHC levels go up, and you can see less free cholesterol in the cells and more esterified cholesterol in the cell media. Can we now, then we looked at these cells in the chronic context. We note that there is a very new inhibitor of CYP46A1 activity called stocostat. So when we repeat our analysis, we looked at essentially the amounts of LOXL1 in the cell media. We see that CYP46A1 cells, they also have more LOXL1 in the cell media in both the soluble and the insoluble LOXL1 fractions. And if you now treat with either stocostat or GSK2033, you can reverse the effects. So there's some kind of a therapeutic angle that we're developing with regards to exfoliation syndrome. Now we also know that this release of LOXL1 away from the ECM could be pathological. So we can predict that in patient aqueous humor, you should find more LOXL1 protein, and it will be more abundant. So this was really what we did. We had a few batches, and we're doing it for multiple batches now. You could see that in especially exfoliation glaucoma patients, you have much more LOXL1 in the aqueous humor compared to controls. So this is all well and good. But what about the LOXL1 variants that I just mentioned were protective? So what is the basis of the protection? So what we did essentially was to make individual cell lines that express these LOXL1 variants. The red ones essentially are protective, they are enriched in controls. Black ones are wild type, common variants, and rare variants that are not associated with protection. And you can see they somehow have less LOXL1 being released into the extracellular space, as you can see in both the soluble LOXL1 and the insoluble LOXL1 fractions. So essentially, protection from exfoliation syndrome comes from these proteins not being able to be released in the extracellular space. This is what our hypothesis is now. So what's the basis of this lack of release? The basis of lack of release, in short, is there is simply less stable in the cells. If you do pulse trace experiments, you can see that wild-type and P317, which is not associated with protection, LOXL1 is essentially very stable. But then if you check the protective variants, they're extremely unstable, and this is caused by them being constitutively targeted for degradation, because you can rescue the phenotype by just inhibiting either proteasomes or autophagy. So essentially, this is essentially what our working model of exfoliation is right now. So normally, LOXL1 in the eye, in the ciliary epithelium, you see that it's nicely in the extracellular matrix of the ciliary epithelial cells. Then, when there's a decrease in CYP39A1 activity or increase in LOXL1 expression, there's more 24-hydroxycholesterol. 24-hydroxycholesterol is a mobile metabolite. It moves. It crosses cell membranes, goes into the non-pigmented epithelium, ciliary epithelium, activates both LXR, causes cholesterol to be released into the extracellular space, which is why you can see more saturated cholesterol in the aqueous humor. Then subsequently, you get LOXL1 being released from the ECM into the into the extracellular space as well, and that's why you can see more LOXL1 in the aqueous humor as well. So I've come to the end of my talk. This is the people working on it. I'd like to thank Dr. Ozaki, who provided most of the aqueous humor samples, and I'm happy to take any questions. Thank you.
Thank you very much. Questions from the floor? Any questions? So what's the clinical implication of this mechanism involving 24-hydroxycholesterol, Zhenxun?
So essentially, the reason why you have more 24-hydroxycholesterol is because there's an imbalance, there's too much CYP46 activity. So one way is to use an inhibitor of CYP46 to decrease the levels of 24-HC so that you don't get the downstream effects that you see in patients. The other thing would be to, I didn't show this, but LXR inhibitors work as well. Also, ER stress. You can use chemical chaperones to make LOXL1 fold properly. You can also alleviate the release into extracellular space. So these are the three approaches that we're currently exploring right now. Yeah.
Right. So you are moving on to prove it. Yeah? Question? Speak to the mic, please. Here.
What's happening to the secreted LOXL1 in these patients? So there's too much secretion, so are they getting aggregated, or what's happening in the ECM?
So that's a very good question. We speculate that the insoluble LOXL1 fraction will serve as a seed for other proteins to bind, and that's how they cause exfoliative deposits. Yeah. So that's the reason why if you have LOXL1 normally in the ECM, nothing happens, but when it gets released, bad things happen. Additionally, there's a second clinical feature, which is aqueous flare. The blood-aqueous barrier becomes compromised. And we think it's probably because of this LOXL1 being released. It's not in the ECM where it enforces the barrier. It's now mislocalized, and that's the reason why you get this phenotype.
Yeah, that's great. So I just have one question about this 24 hydroxycholesterol. Is this what is it acting through a receptor, and what type of pathway it's going out to it?
So 24-hydroxycholesterol is oxysterol. So normally it's a signal for the cells that there's too much cholesterol. So when there's too much cholesterol, it goes and binds the nuclear receptor LXR, liver X receptor. LXR is the effector. Yeah.
Thank you. Now, before our, thank you, Zhenxun, right? Fantastic work.